Welcome to part 2 of nursing care of clients with cardiac disorders. We're going to begin by talking about myocarditis and then follow that up with pericarditis, cardiac tamponade, and valvular heart disease. Myocarditis is an inflammation of the heart muscle and usually results from infection. Most commonly, it is viral in nature. In other words, it's usually a viral infection that causes myocarditis. If severe, myocarditis may result in cardiomyopathy and heart failure. The extent of muscle damage ultimately determines the long-term outcome of the disease. Severe myocarditis may result in cardiomyopathy and heart failure. Myocarditis is often preceded by a nonspecific febrile illness or upper respiratory illness, and manifestations often appear similar to those illnesses. Muffling of S1, presence of an S3, murmurs, or pericardial friction rub may be heard. Chest pain may also be present. Any factor that alters the immune response, such as advanced age, malnutrition, alcohol use, immunosuppression, exposure to radiation, and stress, increase the risk for myocarditis. Medications administered for myocarditis depend upon the likely causative factor. Common medications include antibiotics and antiviral therapy if infection is the cause. Immunosuppressives may be used to minimize the inflammatory response if inflammation is a factor. Heart failure is treated with ACE inhibitors and other drugs, but digoxin preparations should be used with caution. Other medications include antidysrhythmic agents and anticoagulants. Nursing diagnoses include activity intolerance, decreased cardiac output, and also excess fluid volume. And then we have some psychosocial nursing diagnoses that may include anxiety and fatigue. Now we're moving on to talk about another inflammatory condition called pericarditis. As we know, the pericardium holds the heart in place and helps it work properly. The sac is made up of two thin layers of tissue that enclose the heart. And between the two layers, there's supposed to be a small amount of fluid. And that fluid keeps the layers from rubbing against each other and causing friction. Most pericarditis is caused by a virus, and it will heal naturally. There is no specific curative treatment. Ordinary antibiotics do not work against viruses. Pericarditis that comes from a virus usually clears up in 2 weeks to up to 3 months. Okay. So pericarditis is inflammation of the pericardium, and it may be a primary disorder or develop secondary to another disorder. It is usually viral, but affects 40 to 50% of patients with end-stage renal disease and uremia. Heart attacks, acute MIs, and cardiac surgery are also common causes of pericarditis. Inflammation of the pericardium may result in pericardial effusion, fibrosis, or scarring. These changes restrict cardiac function. Classic signs and symptoms include chest pain, a pericardial friction rub, and fever. Dyspnea and tachycardia are also common. So a common complication that we see with pericarditis is a pericardial effusion. Okay, and that is the buildup of fluid in between the layers of the pericardium. When the pericardium is scarred or thickened, the heart has difficulty contracting. This is because the pericardium has shrunken or tightened around the heart, constricting the muscle's heart movement. Medication is administered according to the signs and symptoms. Aspirin and acetaminophen are used for fever. NSAIDs are used to decrease inflammation and for comfort. Corticosteroids may be used as well. A procedure called a pericardiocentesis may be indicated to remove pericardial fluid that builds up in the pericardial sac. Nursing diagnoses include acute pain, ineffective breathing pattern, risk for decreased cardiac output, and activity intolerance. Sometimes fluid collects between the heart and the pericardium. This is called pericardial effusion and may lead to a condition called cardiac tamponade. When the fluid accumulates, it can squeeze the heart and prevent it from filling with blood. This keeps the rest of the body from getting the necessary supply of oxygen and can cause dangerously low blood pressures. A cardiac tamponade can happen when the chest is injured during surgery or radiation therapy or an accident. Cardiac tamponade is a serious medical emergency and must be treated immediately. Cardiac tamponade is treated with a pericardiocentesis. And so to repeat, when there is a rapid or excessive buildup of fluid or blood in the pericardial cavity, the resulting compression on the heart impairs the pumping action of the vascular system. And this is called cardiac tamponade. Pericardiocentesis is a therapeutic and diagnostic procedure in which fluid is removed from the pericardium. The procedure is usually done in an intensive care unit's procedure room or even at the bedside. The physician will insert the needle below the breastbone and apply a local numbing agent and insert the needle and guide it into the pericardial sac. They can use echocardiogram to help position the needle, but frequently they will just use the EKG leads to help with positioning of the needle. And this is what I personally have witnessed, this procedure at the bedside using the EKG leads to help with positioning. Because as the physician inserts the needle, and if he goes too far, he's going to touch the myocardial tissue of the heart. And when there is an irritant to the myocardium, what the nurse is going to observe on the EKG are PVCs. So the nurse's role in this situation would be to notify the physician that the patient is throwing PVCs, because then he knows to pull back on the needle, so that the whole idea is to remove that excess fluid from that space, not to mechanically irritate the heart. So that also can help with positioning of the needle. Once it has reached the correct area, of course, then we aspirate the fluid, and in certain cases they may need to leave a catheter in place to continue to drain fluid from that space for several hours. That would be called a pericardial catheter. In some cases, they even can do a surgical pericardiocentesis when it's difficult to drain the fluid. You may have to undergo a more invasive procedure under anesthesia in surgery. So the pericardium normally contains only a few milliliters, less than a teaspoon of fluid to cushion the heart. They need to get rid of and aspirate the excess fluid. When a patient develops pericarditis, they're going to show a difficulty in breathing, and also, as the nurse monitoring this patient, you're going to see a narrowing pulse pressure. And what that means is that the systolic and diastolic numbers of the patient's blood pressure get closer and closer. Okay, so that the systolic and diastolic blood pressure numbers approach each other, and we say that is a narrowing pulse pressure, and so you have to monitor that for that trend that would indicate a patient has pericarditis. And when the physician aspirates this pericardial effusion, you're going to see the patient's blood pressure, that gap widens. So they move away from each other back to a normal systolic and diastolic pressures. Also, you'll witness before your eyes the patient becomes no longer is short of breath. They're finding respirations are eased. They are able to breathe again. So understand how important it is to improve breathing when a patient has pericardial effusion and cardiac tamponade. So really, I guess I might have misspoken, but what I'm talking about here is a cardiac tamponade situation. That is when you see the narrowing pulse pressure and the difficulty breathing. After the pericardiocentesis, that's when we see the return of the blood pressure to what it was previously, and the improvement in the patient's respiratory status. Now this slide shows all the many things that can cause cardiac tamponade to occur. And there's a whole list of things. Frequently, I've seen it with end-stage cancers, any type of cancer. We can see this occur. We can also see cardiac tamponade after acute MIs, after heart surgery, radiation to the chest, open heart surgeries. All of these things can lead to cardiac tamponades, including pericarditis, which we just spoke about. Valvular heart disease interferes with blood flow to and from the heart. Acquired valvular disease may be a result of an acute condition such as infective endocarditis, or from a chronic condition such as rheumatic heart disease or myocardial infarction. Also, congenital heart defects may affect heart valve function. Two major types of heart disease are stenosis and regurgitation. Stenosis is when the valve opening narrows and becomes rigid. Okay, so stenosis or stenotic valves have a hard time opening, and that causes the lumen there, or the opening there, to be narrow. Okay. And the other is regurgitation, and it occurs when valves are insufficient or incompetent and do not close properly. So those are two other terms that are used interchangeably with a regurgitation. So if a valve is described as being insufficient or incompetent, we are referring to regurgitant. Okay, in other words, it does not close all the way. And that is what we see here on the right side of this slide. If heart failure is present, the client is treated with diuretics, ACE inhibitors, vasodilators, and possibly digoxin. Okay. If atrial fibrillation is present, then we'll also need to consider using an anticoagulant therapy as prescribed. Also, we have antibiotics are prescribed prophylactically prior to any dental work, invasive procedures, or surgery. Surgery and invasive procedures include percutaneous balloon valvuloplasty, open commissurotomy, annuloplasty, and valve replacement. We're going to talk about some of these so you have an idea of what they are. First, we'll talk about percutaneous balloon valvuloplasty. Valvuloplasty is a cardiac catheterization procedure to treat stenosis in heart valves. It is similar to a balloon angioplasty, except instead of opening an artery, remember how we used to smack the plaque against the walls? No, instead of opening an artery, a valvuloplasty stretches open a narrowed heart valve. During the procedure, a deflated balloon catheter is inserted through a blood vessel to the opening of the narrowed heart valve. The balloon is inflated to stretch the valve open. Balloon valvuloplasty is used to treat blockage of the mitral valve or of the aortic valve. So valvuloplasty is a technique aimed at making sure the flaps of the valves or the leaflets close properly. That prevents blood from backing up into the atrium. In the healthy heart, blood flows from the atrium to the ventricle and from the ventricle to the rest of the body. Okay. Surgery is also done to secure the floppy valve leaflets, okay, all in an effort to get valves to close properly. A commissurotomy is a special form of valvuloplasty. Commissurotomy is used when the leaflets of the valve become stiff and they actually fuse together at the base. The base is the ring portion of the valve, and it is called the annulus. Sometimes a scalpel is used to cut the fused leaflets near the ring, which may help them open and close better. In other cases, a balloon catheter, similar to a catheter used in angioplasty, is inserted across the valve. As we said earlier, the balloon can be inflated, splitting, in this case, splitting the commissures and freeing the leaflets to open and shut fully. Annuloplasty is a technique aimed at repairing the fibrous tissue at the base of the heart valve, called the annulus. Sometimes the annulus becomes enlarged, which enables blood to back up into the atrium. To repair this, sutures are sewn around the ring to make the opening smaller. This creates a purse string effect around the base of the valve, and helps the leaflets meet again when the valve closes. And note in this picture where we are using a synthetic ring to replace the damaged annulus and then securing leaflets to that new ring at the base or foundation of the valve. Heart valves may be repaired or replaced. Replacement heart valves are either natural, biologic, or artificial, mechanical. Natural valves are from human donors or cadavers. Modified natural valves are from animal donors like pigs, porcine, which are placed in synthetic rings. And artificial valves are made of metal or plastic. Natural valves rarely require lifelong medication to prevent blood clot formation, that is anticoagulation, whereas artificial valves will require anticoagulation. Now, the advantage of mechanical valves is that they last longer. Thus, the trade-off of lifelong anticoagulation in some cases is worth it to avoid a second valve replacement surgery. Mechanical valves usually last 20 years or more. You are less likely to need another surgery to replace a mechanical valve in the lifetime of a patient. But they can cause blood clots, so patients will need to take warfarin or Coumadin. And so while I'm talking on this point, I want you to understand that anytime we introduce a device into the body's response, natural response, is to form a clot. It begins almost immediately, trying to form fibrin strands and form a clot. So understand that whenever we introduce some instrument or device into the human body, it becomes thrombogenic. That's the natural response when we do that. So we would need to, if we used a mechanical valve, start the patient on Coumadin. Okay, and they would certainly have to monitor their Coumadin levels throughout their life as long as they're on Coumadin. Okay. Tissue valves are less likely to cause blood clots, so patients don't have to take warfarin. Okay, but tissue valves don't last as long as mechanical valves, so the patient may need another surgery to replace it. Tissue valves can last about 10 to 18 years. So this is a very individual decision to be made with consultation of the cardiologist and the surgeon for this patient, because we have to look at the patient's age. We have to look at their gender. Are they a female who wants to have a child? If that's the case, you want to have a child, then we would not want to choose putting them on lifelong Coumadin, because that's going to be very difficult. They might hemorrhage during childbirth. So there are many considerations for the type of valve that would be used to replace a damaged valve. So do make sure you understand this clearly. There are always nursing questions regarding heart valve replacement and the differences between a mechanical and a biological valve.